In the United States, there's about 60,000 new cases of pancreas cancer diagnosed each year, which has been rising. I don't think anyone really understands completely the reason why, but one of the reasons is certainly an aging population. So there are other tests being looked at, being developed, including circulating tumor DNA and other blood-based tests, as well as AI tools to help diagnose pancreas cancer early. Because if we can diagnose it early, we can cure it.
Hello, and welcome back to The Vitals, the Mount Sinai Health Systems show that brings you the latest in medical news, research, and innovation. I'm your host, Leslie Schlachter, a neurosurgery PA here at the Mount Sinai Hospital. Pancreatic cancer has long been considered one of the most difficult cancers to diagnose and treat. But pancreatic cancer is also receiving attention now more than ever. Cases are rising, researchers are learning more about the biology of the disease and new approaches to surgery, radiation, chemotherapy, and personalized treatment that are giving patients and families more options and more reason for hope. So why is pancreatic cancer becoming more common? Who may be at greater risk? And who are the specialists working together to improve outcomes for our patients? Joining us to answer these questions today are three experts who bring different perspectives to the treatment of pancreatic cancer. Dr. Deirdre Cohen, Dr. James Park, and Dr. Karyn Goodman. So before we get into the nitty gritty about cancer and what's happening and treatments and all that, let's just start with the basics. We'll start with you, the surgeon. What is the pancreas? Where is it? What does it do?
The pancreas serves two functions. One is an exocrine function where it forms and delivers digestive enzymes. It helps us digest the carbohydrates, proteins, and fats that we consume. The other vital function that it serves is an endocrine function. And those are from the islets of Langerhans glands that are in the pancreas. And that helps us regulate our sugar levels by producing insulin and glucagon.
So this is the gland in diabetics, like a type 1 that doesn't work well.
Yes.
And where is it exactly?
It's located deep in what's called the retroperitoneum, in the upper abdomen. And that might be why, a part of a reason why the pancreas cancer is difficult to diagnose. Because the symptoms that arise from a gland that is so deeply situated can be somewhat vague. You can have upper abdominal, vague upper abdominal or back pain. And you can have some nausea, some weight loss. These are symptoms that could be attributed to many benign entities that occur to patients. So it could be overseen.
I feel like I've been hearing that a lot lately. A lot of the symptoms of, cancers, we recently learned that colon cancer is on the rise in younger generations, but so many people are on different medications that give them GI discomfort that they're just like, oh, that just must be what it is. And you might miss something like this. Okay, so it's pancreatic cancer. When people hear pancreatic cancer, it's terrible, right? But it's described as a silent disease. So you just explained that the reason why the symptoms are difficult to recognize is because of its location. Are people finding this in early stages or in later stages? Because it doesn't seem like there's a screening test for this.
Yeah, unfortunately, there isn't a screening test for pancreas cancer because for a screening test to be effective, the incidence of the cancer has to be quite prevalent. You also need a minimally invasive and effective test to pick up the disease. And then it has to have a meaningful outcome. And pancreas cancer, unfortunately, doesn't meet the mark on all three, at least as of yet. It's not as prevalent as breast cancer, where you can get a mammogram, not as prevalent as colon cancer, where you can get colonoscopy, screening colonoscopy. And the tests are developing, and we can talk more about that perhaps later about AI and modalities that are coming up.
So what does typically diagnose it? A patient comes in with symptoms. Are they getting blood tests, a CAT scan? How is it usually found?
Yeah, so it depends on where the tumor is located. Oftentimes the tumor is located in the head of the pancreas and it's obstructing the bile duct, and patients become jaundiced and they seek care. Oftentimes when the pancreas cancer is located in the tail or body of the pancreas, then it can go unnoticed for quite some time. But you can have these vague symptoms that get worse. You lose a lot of weight, you have difficulty with digestion, and then or new onset diabetes, which is one of the key drivers of pancreas cancer, or can be a new symptom of pancreas cancer, can oftentimes lead to.
I'm sorry to focus so much on the surgeon, but I know like the patients come to the surgeon, usually do the surgery, and then they make their way to oncology and radiation oncology. So
Although that's changing a little bit.
yeah, so we're gonna like that's like typically how it works. But all right, so walk us through like because I know that I understand that there's an increase in the incidence and prevalence of pancreas cancer. So before we get to the why, um, can we just get to like the basics of generally how people get to you? Because they're not just calling a surgeon as like a primary care, or how are they getting to you?
There are many routes where pancreas cancer patients can get to us, but one route is through their primary care physician. Another route is through their gastroenterologist. And when patients develop these symptoms and they get a scan and a mass is identified, oftentimes that's when the referral is made.
And is it one of those things like when you see it on a scan, it's like textbook, that's what it is? You kind of know?
Most of the time, yes, but oftentimes the scans are not performed in the protocol that we would like. An optimal scan is a pancreas protocol computed tomography CT or magnetic resonance MRI scan. And what that means is that you deliver a certain amount of contrast agent at a specific time, and then you do the scan at certain times while that contrast is flowing through the organs.
So like a dynamic protocol?
Yes.
Yeah. Okay.
Yeah, and oftentimes it's just a single phase study that doesn't quite meet the mark.
All right. So let's put a pin in treatment for now. But it's true. There's an increasing incidence and prevalence of pancreatic cancer. Why is that? Or why do you think?
Yeah, I mean, I think that's a great question. So probably in the United States, there's about 60,000 new cases of pancreas cancer diagnosed each year, which has been rising. And I don't think anyone really understands completely the reason why, but one of the reasons is certainly an aging population. So pancreas cancer is a disease of the aging, with median diagnosis in the upper 60s. Early 70s. And other factors that play a role are, lifestyle choices. So more sedentary lifestyle, increased processed foods, and, chronic inflammation are some of the thoughts behind why it's rising in incidence.
What are you guys seeing in your own practices? Is that all tracks?
Yeah, I mean, most of our patients are older, although we are starting to see some younger patients with pancreas cancer, which is always, devastating. But, in addition to many of our patients, there are no obvious risk factors. We know that there are certain risk factors, as Dr. Cohen mentioned. Alcohol use is a risk factor. But many of our patients are, otherwise healthy, and there is no clear, risk that we can identify. But yeah, the vast majority are probably in their 60s and 70s, and have been otherwise healthy. And then this is something, a new diagnosis that comes on, and we have to decide what kind of appropriate therapy. And I think you were mentioning that surgery is usually upfront.
Yeah.
That
So
actually is
neoadjuvant?
changing.
Where are we at?
Yeah,
Just
that's actually
radiation?
changing.
So how do you guys, so patients diagnosed, you have a lesion. Talk to me about how you guys all interact and how you guys decide to do what you're going to do.
Yeah, so every patient is really looked at from sort of a kind of 360 perspective. And so all three of us, as well as their gastroenterologists, it's kind of a huge team: nutrition, social work, supportive oncology. We all meet. We have weekly meetings where we discuss every newly diagnosed patient, because it really takes a village to care for a patient with pancreas cancer.
Mhm. And so what would you say like the current paradigm is? Is it because you said it's changing? So what has it been and kind of where is it heading?
Yeah, so I think first and foremost, the patient needs to be staged, right? So we need to understand, only about 20% of patients present with upfront resectable disease, meaning that our surgical colleague can fully remove the tumor and get negative margins. The majority of patients, because we don't have a screening test, patients are diagnosed with either locally advanced or distant metastatic disease.
So that means like in the lymph nodes, like or spread outside of the pancreas or somewhere else in the body.
somewhere else in the body or wrapped around some of the major vessels. And so not able to be surgically removed would be termed locally advanced. And so depending on the stage, first and foremost, would help us, determine the treatment algorithm.
Okay.
So it's really important that we have, as Dr. Cohen mentioned, multidisciplinary assessment. So we have our radiologists participate in our meetings. We have pathology because sometimes, there may be findings that our pathologists identify, or even some of the biomarkers that are helpful for making decisions about treatment. But the type of pancreatic protocol CT is really important, that it's high quality, because we do make those decisions about whether a patient is a surgical candidate or not based on the involvement of the blood vessels, and that is really best seen on these high resolution scans.
Okay, so 20% are candidates for resection, and we think we can get good margins. What are the other percentages?
Well, there are 4 buckets, if you will, to categorize patients into. About 50 to 55% of patients present with metastatic disease or overtly metastatic disease. Many of the other category of patients have metastatic disease that are later found, unfortunately. About 10 to 20% are resectable. And then the middle group, the 35%, have either borderline resectable or locally advanced unresectable disease. And with chemotherapy and potentially some radiation therapy, those patients may become resectable in the future. And we are pushing the envelope now. So there are some patients, very selected patients, that have metastatic disease that we have oligometastatic disease, where there are a limited number of metastases. We are actually providing local therapy, such as radiation or ablation or resection or even histotripsy. So that we can treat both the
Histotripsy.
Yeah.
You just blew by that one.
Sorry.
What's that?
Yeah, histotripsy is a local therapy that uses sound waves, but it's unlike, so it's not thermal ablation, where microablation or
Like lithotripsy for a stone.
it's
instead,
similar to lithotripsy, but the frequency of the sound waves are quite high, and they're delivered in spurts, so that it's not the usual HIFU or high intensity focused ultrasound, which uses thermal energy to treat these tumors. This is non-thermal energy, and there's currently a lot of hype/hope around this. It's FDA approved for liver tumors currently.
Okay. So it's time to get excited. Now it's time. So pancreatic cancer, generally people hear that and they're like, oh, so like what right now, I guess in these terrible stages, what is the life expectancy with treatment?
In advanced stage?
Yeah.
So, as of maybe a couple months ago, it was about a year with our standard cytotoxic chemotherapeutics. And so that's what we've been using for decades. Over the last 15, 20 years, we've had multi-agent chemotherapeutics. But what we haven't had so much of in pancreas cancer is targeted therapies. And we know that in pancreas cancer, over 90% of the tumors have a KRAS mutation. And up until very recently, this was a very difficult protein to drug. But at our most recent meeting in June, what was presented and is now published in the New England Journal of Medicine is a new KRAS inhibitor, daraxonrasib, that has shown doubling of the survival in advanced pancreas cancer. And so we are really very, very excited about this new agent, and many on its heels.
That's really, really huge.
Yes, this has been something we've been waiting for, my entire career. So
with medications like this, when they find something, because I know that like in cancer, a month, 2 months, 3 months of life is great. What is this one showing?
So this is
Like
reducing the risk. Well, it's reducing the risk of death by 60%, but in median survival in this study, it increased survival by about 6 months, but that was a doubling. And this is in patients who've already received initial therapy. So in what we call second line
so gold standard
treatment
first, then this.
Yes, but it is now being examined in the front line as well as in earlier stage resectable patients. And so we hope that bringing it starting the medicine in earlier lines of therapy is going to show much even further improved outcomes.
All right. So outcome is good. What about side effects? Because
Yeah.
there's always that discussion.
Of course, yes, everything. There's nothing without side effects, I always tell all of my patients. So, this new medicine does have significant skin toxicity, which we are able to manage and mitigate. But that is one of the main side effects, as well as something called mucositis or inflammation of the mucous membrane, so mouth sores, which also is something we're able to mitigate. And we're learning now more and more how to best handle these side effects. Also common, although not quite as common as the mouth sores and skin rash, are diarrhea and nausea.
The symptoms that they come in with, they also get to have with the treatments too.
That being said, when a treatment works, the quality of life is improved. I always say, to your point, cancer does have side effects, but when the treatment's working, the side effects are going to be much lessened, and patients are feeling better.
Yeah. And then is radiation given concomitantly with these medications, or is it separate? How does that work?
So generally, we give radiation separately, but it has depended over the years on how we give the radiation, and some of that is also evolving. And for many, many years, we used to give radiation with chemotherapy together, but gave the radiation over a course of some almost 5.5, 6 weeks, with a small dose each day. And that was really, really in terms of when we use radiation, it's in the setting of situations where Dr. Park mentioned that tumors are either locally advanced or borderline resectable, where surgery up front or even after neoadjuvant chemotherapy is not necessarily a great option because we are very concerned about leaving positive margins, or not being able to get the tumor out at all. So the radiation is usually either used sort of as an adjunct to surgery, maybe trying to shrink the tumor down and make it easier to get the tumor out with the negative margins along those blood vessels, or in lieu of surgery when we don't think it's another type of local therapy like surgery is, to address the progression of disease locally, because as we talked about, that can cause a lot of symptoms too, like the jaundice and abdominal pain
Right.
and pushing on the bowel or the stomach and causing problems with obstruction. So nowadays, we've moved from using that sort of longer course of chemoradiation to doing shorter courses with a higher dose with each treatment. And we call this stereotactic body radiotherapy, or SBRT. And this is just using more of the new sophisticated treatment planning software and better ability to identify or image the tumor during treatment so we know we're hitting the right spot,
Right.
and limiting the dose to the normal tissues. And that we do both, again, in the setting of patients having disease where we're borderline resectable as a way to shrink it down before surgery, or for our locally advanced patients.
We have very smart viewers that know that there's lots of different types of radiation. What kind of radiation do you give?
So, people sometimes come and ask about proton therapy.
Right.
And so we
That's because they advertise on it on the
yes,
radio.
yes. We do have a proton unit that
Yep.
I have access to, up at the New York Proton Center. Right now, this, nationally, there hasn't been as much of an interest in doing protons for patients with pancreatic cancer because of the bowel gas and the motion. And we can't address that. When the patient breathes, everything moves. So we have to be able to address that. The the exciting thing that I'm hoping to be able to provide for my patients very soon, and we actually are, hopefully in the beginning of 2027, we'll have an MRI linear accelerator, which basically is combining the use of an MRI for the image guidance of delivering the radiation with the linear accelerator all in one. So I can actually, in real time, see what the tumor is doing as I'm about to deliver the radiation, and even change my contours and delivery of the dose in response to any changes in the anatomy, like the bowel might have moved a little bit day to day, or the stomach, so that we can avoid treating some of the normal tissues. So that's going to be available to us within the next 6 months.
Did you guys notice how she got so excited and the smile? Like I've never seen someone so happy about their treatment options. Yeah. Like
I love
you're
my
meant to
MR
be
Linac.
doing this. You're like so happy.
I've only been waiting for it for 6 years.
Okay, so it sounds like essentially you guys have a tumor board. You guys discuss everything, make the decision that's best for the patients. How often do patients say, thanks, but no thanks? Just going to I don't want to go through all of that. Like, what percentage of time do you have those patients?
I would say that's quite rare, but that's definitely always put on the table as an option, and risk benefit alternatives, and that is definitely one of the alternatives is to choose no treatment. I'd say it's under 10%, probably under 5% of patients in my practice choose to have no therapy.
I would like just hearing what you guys are saying about the disease itself, especially like where it falls in the pancreas. Like to me, it's like a neurosurgery. If somebody has a stroke in their ICA, everything's out. If you have a distal stroke, not so bad. So you're like depending on where it is in the pancreas, if you choose not to have treatment, that sounds very uncomfortable. Blockage, like very painful.
Yeah,
That sounds terrible.
yeah, but I think you're hitting the nail on the head. If you have a pancreas head tumor, the surgery that's required to remove that mass is quite complicated. And while we do these cases robotically now, and patients can go home within 3 days and have good recovery, it still is a major operation, and it is
Right.
going to be life-altering to some degree in terms of how you're going to be eating. Potentially, you might become diabetic, or your existing diabetes might get worse.
Right.
So these are all important aspects of the short-term potential complications and the long-term ramifications of the therapy that need to be discussed with the patient. And sometimes it is because we get invested in our patients, and we have a robust discussion in our tumor boards of what this patient should have. And when we go to discuss these options with the patients, sometimes these patients may not quite understand and may opt not to pursue therapy when in fact they seem like a great candidate for it. And it can be frustrating sometimes, but I think that's why we have to listen to our patients and their families members, because they know the best, and they all come with not just a disease process, but they come with a different culture or lifestyle and goals of care that we need to be keenly aware of.
So how do you include those changes as part of the treatment? Like, because, we're not awesome at diet and lifestyle here. Like a lot of us exercise and eat well and still things happen. So how do you include diet and lifestyle changes, exercise as part of the treatment plan for your patients?
Well, as part of our multidisciplinary evaluation, we often have our social worker involved. Our nutritionist is always involved, if not at that meeting, but she's always included in further evaluation of the patient. So we do really emphasize how important all of that is, because a big problem with pancreas cancer is weight loss, and patients are losing weight related to sort of the increased metabolism of having the cancer, but also because they sometimes don't have appetite, or they're just not able to eat because of obstruction. So there are a lot of reasons for them to lose weight. So it is
Is it
really
painful to eat?
sometimes if they have a mass that's pushing on their stomach and they
Okay.
can't, eat in their stomach, when their stomach expands, they actually have pain. So
Okay.
that can happen. Or they have diarrhea. And the other big issue is, as we talked about, the exocrine function of the pancreas is that it makes an enzyme to help to break down food, and especially fats. And so oftentimes you're not absorbing your nutrients. So we try to have all of our patients started on a drug that helps it's basically enzyme replacement that we use to help minimize the amount of, loss of their nutrients. So that's, another thing is our nutritionists are very involved in monitoring their use of this medication called Creon.
Yeah, so it sounds like you really need to think about what nutrients you're putting in your body and not waste stomach space on garbage.
Yeah.
Yeah. And what about exercise? Is there like basic stuff like so for our patients when they're going through surgery, obviously assuming they can walk, we are like very demanding how much walking and movement they do. Is it the same thing for you guys?
Yeah, absolutely. We have a prehabilitation process where ask our patients if unless they have limiting factors like a hip replacement or joint replacement that just does not allow them to walk. But even in those situations, we ask them to do activities that can get around that. But I ask my patients to be walking about a mile a day coming into the operation. And once they're done with the operation, on day one after operation, I expect them to walk a quarter to half a mile. And I actually walk with them. Because it really motivates a patient. It's once they know that the operation's been successful and everything went well, it's easy to say, okay, I have pain, so I'm just gonna rest now. Like it's a huge burden off their shoulders. It's a big relief. So it's understandable that the patients want to get some rest. But I tell my patients that complications don't wait for you to happen. So we're a bit of uh, a driver in terms of getting the patients up and walking. And when they see the white coat coming, they respond.
I think also what's important to note is that patients who have a better functional status to begin with, right, will have better outcomes, both surgically from radiation standpoint and from, medical oncology interventions. And so we want to maintain their functional status as much as possible.
Yeah.
And we also know like exercise is good for everything and as tolerated, of course, but we know that that allows for, lower inflammation, better immune response. So, there's a lot of good reason to encourage continued exercise.
I don't think I've had a topic on any of my podcasts where the risk factors for a cancer isn't like what your diet is and how, like if you're sedentary or not. And then you're going to respond, you're going to do better with treatment. You're less likely to get a condition. You're going to do better with treatment and likely live longer if you eat healthier and work out. It's just like, I don't know why it's so hard for so many people, but okay.
I think it's our society.
Yeah.
That's a bigger discussion.
Yeah, that is a bigger discussion. It is hard. I mean, cell phones are a problem.
Yeah. But it does point to that population of patients that are have a rising incidence of pancreatic cancer right now, which are the younger female population. And it hasn't been worked out specifically in terms of why that population has a higher incidence compared to younger men or other subgroups. And the other groups, as Dr. Cohen mentioned earlier, it is a disease of aging. But this population, at least it's not due to smoking. It may be slightly related to alcohol consumption, but more and more younger folks are not drinking alcohol.
Right.
But there is a link to central obesity. And as you were pointing out, with central obesity and metabolic syndrome, I think patients are, and that's specifically for female patients. So I think having a good exercise regimen and eating healthily is vitally important. It's those things that are easily said, but more difficult to carry out.
It really is. It's unfortunate that there's not something like a mammogram or a colonoscopy. What about these? I've done them myself. What about genetic testing? The ones you can you swab the inside of your cheek or spit into a cup and you send it out. Is there a genetic marker that we can look for on these testing that puts you at a predisposition?
Certainly, about 10%, up to 10% of pancreas cancers have a genetic component a hereditary genetic component from mom or dad. Most notably, BRCA is the gene that we look for. But in every single patient that's newly diagnosed with pancreas cancer, we are doing genetic testing, both hereditary genetic testing and then genetic testing on the tumor for targetable mutations. So there is certainly for patients who have a hereditary risk factor, those patients should be enrolled in a high-risk screening program, which we have here, to try right now. Those patients are getting imaging studies as well as endoscopic ultrasounds alternating every 6 months. But there are other tests being looked at or being developed, including circulating tumor DNA and other blood-based tests, as well as AI tools to help diagnose pancreas cancer early. Because if we can diagnose it early, we can cure it.
Yeah. And I guess a laparoscopic exploratory surgery is not a good screening tool.
That's a little bit invasive, but as Dr. Cohen was mentioning, there is an very exciting AI tool that's out of the Mayo Clinic called RedMod.
Okay.
And basically it uses radiomics signatures and and they did a study looking at patients that happen to have had CT scans in the past and unfortunately developed pancreas cancer much later. even 24 months ahead of that diagnosis, more than 60% of those patients would have been diagnosed based on this AI algorithm. So it's an amazing technology, I think. And I don't think this is going to be unique. I think there's going to be many more such modalities.
So what does it see?
It sees, I'm not
From your understanding, what do you
yeah,
think it
a
sees?
technical expert or anything, but yeah, it takes this, apparently 14 different signatures that humans cannot detect in the CT scan. And there are these CT scan, at least speaking to my colleagues, the dual energy CTs that can take specific pixels of a CT scan and take the information from that individual pixel and see if there's something wrong with that, the information that's contained within that pixel. And then they gather all of those signatures and run it through the algorithm, and they can predict whether there's some distortion of the architecture within the pancreas that shouldn't be there. And they validated this in the, I think, 800 plus patients that they were able to look
So
at.
theoretically, prospectively, that could be used moving forward
Yeah.
and picking up. That's amazing. I feel like what you guys have brought up, like with the technology and everything, especially your exciting MRI thing, it sounds like technology is really helping out for the treatment.
Yeah.
Do you think that you're going to see any notable changes in outcome from all of this for patients?
We have seen improvements. When I first started doing this, the 5-year survival for pancreas cancer was 6%.
Oof.
And now it's about 12%. So that's all comers, but it's, we've improved, we've doubled the survival. It's still not where it should be. But I think all of these things, I mean, my feeling is that, we've made a huge amount of progress since I started doing radiation for pancreas cancer and being able to target it in a much more focal way, reduce side effects, give higher doses that may be more effective. And right now, we're even doing very, very focal radiation where we can actually turn the beam on and off with the patient's breathing. So I couldn't do that, 15, 16 years ago. That was really something we started, back in the late 2000s. So, or maybe 2010s or something like that. So it's really something that we've changed quite a bit in terms of delivery. And I think now having new approaches with systemic treatments, with targeted agents, there are all these new ones that are, sort of in development. And those things couldn't have been done also, without the science that's sort of progressed over the last 10, 15 years. And surgery is, with robotic surgery, I think it's, a huge improvement. I mean, 3 days in the hospital after a Whipple is pretty amazing. So these are things that are going to really improve outcomes and, quality of life for patients.
Yeah. And it sounds like this new medication, when you finally get your hands on it, big deal.
Oh, we have our hands on it.
Oh, good.
So it's not yet FDA approved. It was submitted, they filed with the FDA, but we have an expanded access program. So it is available for our patients, and we are
What does
treating
that mean, expanded access?
So the FDA has a early kind of ability is allowing distribution of this drug through various sites who go through all of the application process. So we have done that, and we are using it. But I don't want to. This is a very important medicine. But as Dr. Goodman was alluding to, I want to just say this is just the beginning. So the fact of the matter is, we have an ability to target this mutation that is one of the drivers, right? It's like the foot on the gas pedal in pancreas cancer. But there are many other agents that are being developed, and we're going to get better and better, and there'll be fewer and fewer side effects. And I think in terms of being hopeful for pancreas cancer, not only do we have these targeted agents, but I think being able to diagnose the disease much earlier, which we're getting better and better at, and then being able to use these targeted agents, I think we really will see, within the next 10 years, a massive improvement in outcomes. I really feel strongly. So I think all the technology and all the different arenas is leading up to this. Early diagnosis and better treatments, as you said, screening tools can only be good if you actually have the treatment to improve outcomes. So just finding the disease without a good treatment doesn't help.
So as we wrap up, what would you say your message would be, whether it's to a patient with a new diagnosis or their family, knowing everything that we know with all this? What's your message? What do you explain to them?
I'll go ahead and say,
Yeah.
I think there is hope, and I tell my patients this every day. I think they need to go to a academic center where there is multidisciplinary care, where they're getting the genetic testing that they need to be getting, both hereditary and on their tumor, and where they can see, doctors and other providers, nutrition, supportive oncology, have good radiologists, pathologists, where everyone comes together so they can get the best comprehensive treatment plan for themselves. And that's where we know, studies have been done, that outcomes are best in that environment.
Well, I actually did have a family member with pancreas cancer recently, and she was treated here, and she's now 4 years out. Fortunately, hers was, this is my stepmother. She it was picked up very early. She had her surgery here. She had her chemotherapy afterwards. And, I told her that she had the best case scenario, that it was surgically, she had a tumor that was in in the body of the pancreas, and it was picked up sort of on an ultrasound that she was having for a different reason. So it was very lucky. But I think, what Dr. Cohen said is, if we can get these, identify these tumors early, that gives us the best chance of cure. And so, focusing on better methods of prevention, screening, new ways of using AI to help us evaluate whether it's, you know, imaging, or also, finding risk factors in the population. Those are all going to be ways to improve identification of these cases early. So, and I am hopeful, and it's good to know that, also the treatments are getting better too for our patients.
Wow.
Yeah, there's no doubt that pancreas cancer is a formidable foe, but I want patients to recognize that you have a team, a village, as Dr. Cohen said earlier, that's behind you, and working for the common goal. As a surgeon, it's commonly said that, without surgery, the cure is not possible. But I like to think of it slightly differently. The way that I think about cancers on the spectrum, you can have cancers that you do surgery for cure. Pancreas cancer is, even though I'd like to think that I could provide cure, I'm not naive, and without my colleagues, optimal care cannot be provided. So pancreas cancer currently is on the other end of the spectrum of compared to, say, a very small thyroid cancer in a young patient that can be resected and they're cured,
Right.
essentially. But we're getting to a point with these exciting new treatments, whether it's MR-Linac or daraxonrasib, and I'm very excited because it allows those patients that are currently not resectable to potentially become resectable,
Right.
and potentially not even need a surgery in the future. And that would be a great thing that happens, hopefully, in my lifetime.
So one of the things that we didn't really get into today was access to care. And one of the things that I have found from a lot of the podcasts that I've done is, like, there are people out there that don't have insurance. So what happens when someone comes to the hospital? Let's say they come in, they're sick, they're vomiting, they're in the ER, yada, yada, yada. They're found to have this and they're not insured. Can we still help them? Can they join a research study? Is there something we can do?
Well, certainly we're going to find them help. And when they're in the hospital, they'll be treated. And I know that Dr. Park has operated on such patients who are uninsured or underinsured.
Social
Yes,
work
yeah.
can really be so helpful. We had REAP. We have all these great
Right.
options that are, there to help our patients who don't have insurance. And so the social workers are key also in all of this.
Because that's a big deal. I mean, if someone's at home and they know they're sick and it's getting worse, they might be really afraid because they're uninsured, and that should not be a reason. Like, because we can help. We can help.
Yes,
Yeah.
definitely.
Yeah.
Yeah, I saw a patient back in post-op today, prior to this podcast, and it's a patient, of Korean heritage, and he had emergency Medicaid, but it didn't cover the surgery. So the children got together and scraped up as much as they could, and unfortunately, he didn't qualify for charity care, and they were wondering whether they could just pay half of the fees. We gave them an
Right.
estimate and things of that nature. Thankfully, there was a patient that we had treated a while back, who was from Toronto, and I don't know why, but somehow found us and wanted to have treatment here at Mount Sinai. And she had received...
Because we're the best.
Sure. And she had a great hospital stay. The estimate was for a 7-day hospitalization for distal pancreatectomy splenectomy for pancreas cancer. And I thought it was a somewhat outrageous estimate, but we're taking into account potential complications that might occur after the operation and such. She did great, left on day 2, and she got a significant refund of over 70%. And that was one mechanism of allowing patients to get their care that they need.
Yeah.
But as Dr. Goodman stated, we have great social care mechanisms here to try to...
Yeah, that's just important for people to know that there's help. That's not a reason to
Yes.
stay home. So that's all for this episode of The Vitals. I'm your host, Leslie Schlachter. Subscribe to The Vitals and the Mount Sinai Health System's other programming on YouTube, Apple Podcasts, Spotify, or wherever you get your podcasts. If you want to learn more about Mount Sinai's work in pancreas cancer treatment or to book an appointment with a Mount Sinai expert, scan the QR code on your screen, or you can click the link below in the description. If you want to get in touch with the show or suggest an idea for a future episode, you can email us at podcast@mountsinai.org.